All right, class. We're going to go on to a drug here that's it was a lot more popular maybe 15, 20 years ago. It's fallen a little bit out of favor, but I will tell you it still has really good uses. And of course, the drug I'm talking about, of course, is atropine, or atropine sulfate is the official title is for it. Again, we commonly call it atropine just as a short version, but it's atropine sulfate. And again, it's that was a pronunciation of it phonetically, and we use it to help speed up the heart or to stop vagal tone from happening. And we'll go into that a little bit deeper here in just a second. It's actually a derivative of the belladonna plant, and therefore it works against the parasympathetic system. It blocks the parasympathetic system. So a little quick review of the sympathetic parasympathetic system. Sympathetic speeds it up, fight or flight. Parasympathetic, rest and digest, slows us down. Okay, and again, both parts are very important for our body to work. During the rest and digest, it kind of slows everything down, allows our food to process, it allows our lungs to go a little bit deeper. So it has really good effects to it. But the problem is that again, that's what we're actually using to turn off that parasympathetic system with atropine. So it blocks the acetylcholine receptors, the parasympathetic nerves. So that's exactly what it does. The blocking action enhances both the sinus node and the atrioventricular conduction. It allows the heart to speed up naturally. So understand this, that in order for that to work, you have to have a couple things that actually function. The first thing is the sinus node and the AV node, and they're both working the way that they're supposed to. If they're not working the way that they're supposed to, atropine's not going to do any good. If those nerves have been cut, it's also going to, it won't work because again, it works on the nervous system. So somebody that's had open heart, has had a heart transplant, atropine does not work. Okay, it speeds up the heart by basically turning off that slow down process, and so but it does not have any effect on the squeeze of the heart. So the inotropic effect, he has no involvement with that. And then it's also the antidote for your organophosphate poisonings, and that would be your sludge effect: salivation, lacrimation, urination, defecation, gastrointestinal effects, and emesis. That's your sludge. And then the M is on the other one, is myodritis, or meiosis, sorry, goes down and makes pupils small. So, by the way, that is another use for atropine, and we'll talk about that when we get there. It's used, by the way, to treat respiratory emergency because it dries up respiratory secretions. And that, again, makes us a little bit better as far as helping our breathing a little bit. And it does decrease peristalsis. It increases urinary retention. So when you give the folks this, and they've got urinary tract problems, again, you're going to have a little bit of a problem there. It increases central nervous system stimulation. Again, it works directly against the parasympathetic system. So the good news is once you push this stuff, it is immediate, okay? And then it lasts for around 2 to 6 hours. However, every now and then you're going to notice that on your cardiac patient, you might end up having to rebolus them in certain situations. It does happen. So again, we usually give them a little bit of atropine to see if we can speed up the heart rate using that method. We use it for sinus bradycardia, and I would like to really stress that. Sinus bradycardia, first degree block. It works very well against those guys. By the way, they need to be symptomatic, hemodynamic compromise. They're high, they have a low blood pressure. They're confused. Lots of extra PVCs when they shouldn't be having it. Pale, cool, clammy skin. They don't look good. Okay. Low blood pressure is another big one. You just got, again, that's when we want to engage atropine. Atropine works very well in those situations. Your organophosphate poisonings. In other words, you got sprayed with malathion or rigid bug or 7 dust. Again, most of your common ant and roach sprays are organophosphates. They use a lot of these on farms as pesticides. Um, and again, they accidentally get sprayed, by a crop duster. That would be a good example of they would get it through their skin or breathe it in, which will make it, of course, even worse. That's the one where they show up with that sludgeum. They got stuff coming out of every orifice. I once had a patient who drank a whole bottle of malathion, and before we could even get him to the hospital, man, he had stuff coming out of him that was just absolutely crazy. And I emptied the truck of atropine trying to reverse it. Bronchial asthma, we use it to help, again, remember that apotropium bromide is an atropine derivative. So we do use it in certain cases of asthma, chronic bronchitis, emphysema. So that does have some good effects there. If they have signs of, again, the organophosphate poisoning, this is our drug to use. And we use this to stop somebody from having a vagal response. When we're sticking a laryngoscope in somebody's mouth, that's a good example of a vagal response. Especially our pediatric patients, 2 years of age or less, is getting a drug-assisted intubation. These guys, we most definitely want to make sure that we do that. Now, there we go. I'm back. So again, remember that a pediatric's blood pressure is very dependent on their heart rate. So in order to keep up the blood pressure on the peds, we make sure that heart rate keeps going the way it's supposed to. When you stick a laryngoscope in somebody's throat, again, you're going to have that problem, I assure you. It's going to definitely slow down a kid. And with that being said, we want to make sure that we pre-medicate them with atropine so the heart rate does not fall. Now, we do not use it in pediatric cardiac arrest. One thing you might see is it was used for cardiac arrest back about 10 years ago if the patient was in a systole or PEA. That was used to speed up the heart rate. Guys, epi does that just fine. Okay, epi 1 milligram every 3 to 5 minutes. Unless they got some reason that you think that they've got a vagal problem, that is the only time that you would use it in cardiac arrest. And I can tell you right now that that's kind of a rare thing to happen. Now, again, our side effects. And matter of fact, I've got a slide on this a little bit later to kind of help you remember. By the way, one other thing atropine does do is it dilates out the pupil. Very much dilates out a pupil. So that's why Spidey's over there. He's got mydritis. Mydritis is a very normal thing that's going to happen with these patients. But again, they usually get very dry. They'll get a dry mouth with this. A little bit of nausea, vomiting can happen. They may get a little bit of a headache. Again, the dilated pupil is what is actually supposed to happen. When you go to the eye doctor and they dilate your eye out, that's what they're using as a form of a derivative of atropine to actually dilate the pupil. So again, but the problem with it is that it does cause tachycardia. It can cause hypotension just because of the shift in the way that the heart activates to this. Especially if you give too little atropine, you can actually get a rebound bradycardia from that. Or when you push it slowly, or you push it at a very low dose. Okay, so this is one of those that we actually want to give with a good solid push. Okay, we don't want to do it just creeping along there. If we know that they're sensitive to the belladonna plant or alkaloids, we don't give this. If they're having a heart attack, atropine is not what you want to give them. Here's why. If you give them atropine, it's going to speed up their myocardial oxygen use. And obviously, that's at a premium when they're in the middle of a heart attack. So don't give atropine during the heart attack situation. There's other agents that work better to do that. Don't use the atropine, okay? And then again, if they are tachycardic, don't push atropine. They're going to get more tachycardic, okay? I commonly say this in ACLS. You got to know the difference between your A's. Atropine, adenosine, and amiodarone. One numbs the heart, one slows it down, one speeds it up, okay? Now, Again, your relative contraindications. If they have glaucoma, AFib or AFib, you really got to be careful with that one, because if it starts speeding up, remember that you don't really have SA node control at that point with AFib or AFib. AFib, you usually have an irritable foci somewhere, but it will start speeding it up through the conduction through the AV junction, and that can cause some problems. If they got COPD, we sometimes use it for that, so don't exactly go there. And again, there's no contraindications. Again, if there's an organophosphate poisoning, if they're showing signs of organophosphate poisoning, we want to give this stuff in earnest. Matter of fact, you probably do not have enough on your truck to actually start reversing. You got it to start reversing, but you're going to need a whole lot more. All right. So again, just remember that anticholinergics, they can increase the vagal blockade, which can cause problems. It's gonna slow down. It's gonna make that work even better. The effects are enhanced by antihistamines, procainamide, quinine, antipsychotics, benzos. Again, all of these things is gonna cause atropine to work a lot better than it's going to work with them. And antacids slow the absorption of anticholinergics, and this can be reversed with physiostigmine. But I will tell you that, we don't carry that particular flavor of ice cream usually. Again, it very much dries up mucus plugs. So if you've got somebody that you think's got a mucus plug, you might want to think about it before you give it. And again, if you give too less of a dose, less than 0.5 in an adult or less than 0.1 in a child, they're going to slow down on you even more. So when you decide to push this, make sure you push at least the minimum dose, okay? You can't go, well, I'll just give half the dose. Nope, you're going to make them worse, okay? Again, if you give them too much, by the way, it can cause delirium, coma. You can actually put them into VFib or VTAC, because, again, if it slows down too much, the ventricles are going to take over, because, again, they're not really happy, or they'll just start to fibrillate on you, okay? And the reason that we like to use this in RSI is, again, to prevent bradycardia, number one. So if I got somebody that's kind of bradycardic, I usually give them atropine, because it does one other thing. It helps dry out the mouth. So again, if you're deciding to give atropine, give it early so that it's got time to work, okay? Although the onset is immediate, the action, especially drying up the mouth, might take a minute or two to actually do. If you got a second degree or a third degree block, you can actually worsen by giving atropine. So don't do it. Go straight to transcutaneous pacing, okay? If pacing is not available, actually atropine is not the one that I want to use. The one that I really want to use is probably some sort of catecholamine, a dopamine, or an epinephrine drip, okay? And again, if you got victim of organophosphate poisoning, sometimes they can take a highly excessive amount of atropine to actually get them to the point. And you start looking for signs of atropinization. And what that's the giant word, meaning they start to get dry, they start to get flush, their pupils start to dilate, okay? And actually the heart rate will speed up, okay? It will be very instant and immediate when you see those results happen. They'll go from a heart rate of 10, 15, all the way up. Now, if you do overdose them on atropine, these are things that you're going to see. They're going to be hot as a hare, mad as a hatter, red as a beet, dry as a bone, okay? So if you can remember that little phrase there, if you start seeing those signs, yep, you've given too much atropine, okay? So, and usually if you just let it go for a minute with the mild signs, they usually get better within just a little bit of time, okay? Again, physiostigmine is your antidote for this. How we give it. 1 milligram in 10 milliliters is your pre-filled syringe, or quote-unquote the purple box, all right? We usually give it, there are also the 8 milligram vials, and also don't forget about the auto-injectors. It's part of your Mark 1 kit. The military use, they usually have them in 2 milligram, 1 milligram, and 0.5 milligram dosing, okay? But again, those are the auto-injectors. These are the ones that they have underneath the stadiums. So if somebody attacks the stadium, they start handing these out, and everybody starts getting them in the leg. They just literally just pump them full. Adult dose, again, bradycardia is usually 0.5 milligrams up to 3 milligrams is your usual max out. Again, if it's a bigger person, you can go to 4. Smaller person, I might hold up at 2. Okay. If it's an organophosphate, we usually give 1 to 2 milligrams initially. If they don't get better, we give 2 to 5 milligrams, and if they still don't get better, we need to call poison control or med control and figure out how much we're going to actually give this person. I want to stress this about bradycardia. Only if it is a sinus bradycardia or a first-degree heart block, and I'm even a little bit leery about a first-degree heart block, but only if it's sinus in nature should you be using this on a bradycardic patient, okay? If they've got a second or third degree heart block, guys, don't give atropine. It's not going to work, okay? Your pediatrics, again, these guys usually don't have heart problems, but again, 0.02 milligrams per kilogram is your dosing. And again, the minimum dose, by the way, is 0.1 milligrams, okay? And usually your maximum dose for a bigger child is 1 milligram. For your smaller children, 1 to 8, I would say 0.5. Even your infant, guys, we don't use atropine except for basically your RSI procedure. If we're wanting to speed up the heart rate with kids, atropine is not our drug. Epinephrine is our drug, okay? So keep that in mind. The reason that we give atropine to kids is to prevent bradycardia while we're doing the drug-assisted intubation, okay? Again, we can give it IVP, we can give it IO, we can give it down the ET tube, but again, and actually the other route that I didn't put in here, remember I said that the eye doctors use it to dilate the pupil, so you can see it in eye drops. We just don't use it in the EMS for that setting. And again, it's a pretty safe drug. I've used it on pregnant patients before for really weird cases, but we've used it on pregnant patients before and it's been okay. So they really haven't seen any issues. All right, I know this is a little long, but again, lots of stuff to go over on this particular one. I will see you guys on the next video.